Okay, we're continuing on with chapter 9. Yes, I realize this is a very long chapter, but it all is very, very important. So, cardiovascular system now. You want to look for trauma first, feel around for um, stability of the chest itself, for the ribs and everything. They shouldn't crackle, they should be strong under your hands. And then listen for breath sounds. This is going back to that inspect, palpate, auscultate. Then you want to consider the pulse, respiratory rate, and the blood pressure. Make sure that they all make sense. Pay attention to the rate, quality, and rhythm of the heart. If you're listening, you can do that. You can check a pulse in order to see that. Typically, you can tell if a rhythm is faster than normal, slower than normal, or feels pretty regular. Quality, is it strong? Is it bounding, meaning more than strong? Or is it weak and thready? And then rhythm, is it normal? Heart rhythm should be pretty darn normal, but if somebody has a condition where their heart is beating erratically, you're going to feel that with their pulse. Consider your findings when you assess the skin. The earliest extremely noticeable sign for low blood pressure or shock is a patient who is pale, cool, and clammy. So that will happen well before their blood pressure starts to fall significantly, where you're like, holy cow, they are definitely in shock. We can catch it well before that. You want to check and compare your distal pulses, see if they've got some in their wrists, see if they've got some in their feet. If there's a difference, obviously it's a lot shorter to get it to your arm than it is to get it down to your feet. So you should be able to tell that something's not right. If there's something that could be wrong with your patient's heart, especially in the presence of trauma, you may want to auscultate the heart for abnormal heart sounds, just in case. Pulse rate. So normal resting rate, like we talked about earlier, for adults is about 60 to 100 beats per minute. If their heart rate is greater than 100 beats per minute, it's known as tachycardia, tachy being fast, cardia being the heart. If it's less than 60 beats a minute, it's described as bradycardia, brady being slow, cardia being the heart. Keep in mind though, the younger the patient, the faster the pulse. If your pulse, just like respiratory rate, is regular and relatively normal, you can go ahead and count for that 30 seconds, multiply it by 2. If they have an irregular heart rhythm, you need to go for the whole minute to try and measure that appropriately. Your pulse quality, stronger than normal, like I said, is called bounding. One that is weak or difficult to feel is weak or thready is really the term that we use. And that's not a I can't feel it at all. If you can't feel it and you know you're in the right spot, it truly could be absent. Pulse rhythm, regular, each contraction is relatively at the same interval, constant. If it's irregular, you can have a heart that's beating fast and then slows down, beating fast and then slows down. You can have a beat that's dropped. So they're going along, going along, going along, and then you don't feel anything. And then it starts going along, going along, going along, then you drop a beat. It could be that they have extra beats. So everything is doing just fine, and all of a sudden they have an extra beat that comes out of nowhere. You're like, whoa, what the heck was that? So you want to check for regularity as well. Blood pressure. So we've talked about this before. It's the pressure that's exerted against the walls of the arteries when the heart pumps. In order to calculate blood pressure, you end up taking that stroke volume, so the amount of fluid that can be pumped in one beat, stroke volume by the heart rate, and then times the peripheral vascular resistance, so the amount of force the heart has to pump against in the arteries in order to move blood forward. A drop in blood pressure may indicate that you've lost blood or fluid components, you've lost vascular tone and sufficient constriction, or you have a cardiac pumping problem. An easier way to think of this is you've got three major components to the cardiovascular system. You've got the pump, which is the heart. You've got the container, which is going to be your blood vessels. And you've got the content, which is your blood that's circulating around. If you have a problem with any of those three components, the other two need to fix what they're doing in order to fix the problem. So if you have a loss of blood, what's going to happen is your vessels are going to constrict or shrink down. The lumen, which is the inside, it's going to make that smaller so that your blood pressure goes up. Your heart, the pump, is actually going to speed up as well, so it's circulating more blood faster. If it's a loss of vascular tone that's going on, your body can't make more blood that quickly. So what we end up doing, and I mean medical professionals because you as EMTs won't be able to, is that we give them IV fluids in order to increase the amount of contents that they've got going around. And then your heart speeds up. If your heart is the problem, your vessels are going to constrict down again, and you need to give IV fluids to get their blood pressure up. A decrease in blood pressure, significant decrease, is a late sign of shock. We want to catch it well before that. So a patient that's tachycardic, that has pale, cool, clammy skin, that has a mechanism of injury or nature of illness that is along the lines of fluid loss, we should already have that picked up well before their blood pressure starts to drop. And that's in most patients. There are those severe trauma patients that they're already there before we can do anything about it. On the other portion, abnormally high blood pressure, your body doesn't withstand that very well. If you think of it as something just continually ramming into that vessel wall, eventually your vessel wall is going to give way because it can't just take that much abuse over and over and over. It's not made to do that. So if it's taking that much pressure all the time, what's going to happen is that that wall is going to start giving way and it can rupture. In order to measure blood pressure, we use a blood pressure cuff and a stethoscope. The components of that, you have the wide outer cuff that you actually can see that you're going to put against the patient's skin. Within that, there's an inflatable bladder that's actually going to pump up, and it's going to close off that brachial artery. You have a ball pump with a one-way valve, so the little squeezy thing that you put air into the bladder with, and then a pressure gauge. Auscultation is normally how we do this because then it gives us a systolic and a diastolic reading. You can do it by palpation, where you actually feel your patient's pulse within their wrist as the blood pressure cuff is decreasing in pressure, and as soon as you can feel the pulse, that's the systolic pressure. However, your patient has to have high enough blood pressure to produce a radial pulse. So that really can't be used for everyone. And we'll go through this on lab day as well. Normal blood pressure, your systolic, averages between 90 and 130. If they're under 90 millimeters of mercury, that's called hypotension, hypo being below or less than. And if it's above 130, they have hypertension. Now this is just in that instance. In order for somebody to be diagnosed with hypertension, typically they have to have a systolic pressure greater than 140, a systolic pressure greater than 90 at two separate instances. So they go to the doctor, they get measured, and it's there. They go to the doctor the next time, they get measured, and it's there. And typically what doctors will do to make sure that they're not misdiagnosing is they'll take the blood pressure at the beginning of the visit and then they'll recheck it at the end of the visit because some people are just nervous when they go to the doctor. So once you get everything out of the way and they're like, okay, you're relaxed now, let's go ahead and check that blood pressure again. Make sure that it was accurate and it wasn't just anxiety. Your neurologic assessment. There is not a whole lot that we can do with neurologic assessments in the field. We can do mentation, um, we can do checking like mental status, but really it doesn't go much further than that because most things that are going wrong with your brain, you have to have scans for. So we want to try and do at least our basic neurologic assessment with anybody that has change in mental status, anybody that has a potential head injury, that has stupor, meaning they're just lights are on but nobody's home, dizziness or drowsiness, the drowsiness that's more than normal. And then syncope. Syncope is just fainting. Somebody that's fainted or even near syncope. We'll do a neurologic. So evaluate the level of consciousness. We've already talked about that and their orientation. The AVPU scale, if appropriate, it should be appropriate for the majority of your patients. And then the Glasgow Coma Scale can be helpful as well. Glasgow Coma Scale is also called the GCS score, and it can test the parameters of the patient's eye opening, their best verbal response, and their best motor response. The combination of the three will give you a numeric score that will tell you how your patient is doing overall. If they have the max score, which is 15, GCS of 15, they know they're doing pretty good. Once you get down below that 13, we know that there's something that's not quite right with the patient. Something's off. And if they get down to 8 or less, that's more of a critical patient. Pupils. We can test neurologic response by checking the pupils. The pupil is that black center portion of the eye. Generally, they are round, approximately equal in size. And then if you put light to the eye, you only want to do it to one eye. They should constrict, and they have sympathetic constriction. So that means that if you only shine the light in one eye, the other one is going to move with it. If you pull the light away, they're going to dilate or get bigger together. They move at the same speed relatively. So here's some of the lookings of pupils when you assess them. The top one, those blue eyes, they're constricted. When light becomes brighter, your body doesn't need as much of it in there to see what's going on. So you end up constricting down so that not as much light gets in. When it's dark out, your pupils end up getting bigger because you need more light in to define things that you're seeing. When they're unequal, that could indicate that you've got an injury to your brain, you've got pressure up in your brain that's actually pressing on the nerve. Keep in mind that just because they're unequal doesn't necessarily mean that they have something going on. You need to take some history because there is a small population within the world that has what's called ansecoria. That is, they were born with unequal pupils and it stays that way all the time. If your patient is adult or older, they may have had cataract surgery. When they have cataract surgery, their eyes don't dilate the way that they should. So while this is something that's, something that we want to check, it's not the end all to be all. There can be causes of depressed brain function other than trauma that the pupils will kind of let us know what's going on. Stroke is one, a brain tumor, inadequate oxygen or perfusion. Your eyes are not going to dilate like they're supposed to or constrict like they're supposed to. Drugs and toxins do the same thing. And you can kind of tell which general class of drug the patient may have taken based on how they present. So if they take a stimulant, stimulants tend to constrict. If they take a depressant, depressants tend to dilate.